Hello, everyone, and welcome to Doc Talks, episode 21. Today, I have with me a allergist who specializes in pediatrics, Dr. Gillian Bassirpour. Good morning, Gillian. Thank you for
Good
being here.
morning. Thanks for having me.
I am going to start with a short background about who you are and what you do, and then we can jump into our questions on pediatric allergies. Thank you to anyone who's here joining us. Please feel free to text or type your comment questions, and we will add that to our discussion today. So, Dr. Bassirpour is a board certified physician in allergy immunology. Her family recently moved from Michigan to California, and she has since started her mobile pediatric allergy concierge practice. Her educational background includes the University of Michigan for undergraduate school and Wayne State University School of Medicine for her medical school. She completed residency at the University of Michigan and then a fellowship in allergy immunology at Henry Ford Hospital. She joined the faculty at Henry Ford and practiced there until moving to California. During her time at Henry Ford, she initiated a food allergy program focused on early introduction of allergenic foods in infants. She has performed numerous oral food challenges and assisted in the department's research activities related to food allergy. Her current practice is focused on convenience for the family, and she strives to provide compassionate care in the comfort of your own home. You can learn more about her at ryanrayskin.com. I will include that in the comments. And is there anything I missed in your impressive history in
No, I
medicine?
think you got it all. Thank you for that. I'm very excited to be here to talk with you. I'm very excited to be in California in general. So, just overall, very excited.
Well, this is not a topic missed on any new parent because we're always waiting and watching to see should our child develop any signs or symptoms of allergy. So let's start with the newborn or young child. What would be some of the things to look out for and not to even skip over the whole history too, because I think we forget to ask parents about their history with
Mm-hmm.
allergy.
Yeah, so I think it's important when you're asking signs of a food allergy. The first thing I like to kind of do is let's define what allergy is. That term is just so loosely used, and it's actually pretty specific. So, I kind of describe there's an umbrella term for adverse reactions to food. So, what is that? I mean, that's pretty much what it sounds like. Any untoward effect of eating a food, anything that's not supposed to happen, and there's so many examples of that. Even food poisoning, is an adverse reaction to food. But allergy is an abnormal, immune response to a food. And even more detailed than that is it's an IgE mediated response, which that sounds, kind of medical, but it's just a certain antibody in our bodies that are causing an abnormal immune response with very specific signs and symptoms. So when you think about a food allergy in a newborn or child, I think that there's two common ones. One of them is the IgE mediated one, which is the classic allergy symptom. And then another one is something that you see, probably even more common than I see, is proctocolitis or blood or mucus in the stool. So we can talk about that one after. But a true food allergy in an infant is the classic allergy symptom. So if a baby, an infant is introduced to milk for the first time or egg for the first time, they're having signs of a classic allergic reaction. They may develop hives, which look like mosquito bumps. Their lips may swell. They may start to vomit. You may hear wheezing, coughing, runny nose, diarrhea. And it happens within minutes, and up to 2 hours. And that is the classic food allergy example.
So, in
Um,
summary, you're talking about hives, vomiting, diarrhea, period,
yeah,
and
wheezing.
wheezing. And you're saying the first exposure, but we're classically told it's a repeat exposure. Are you saying because they're breastfed or they've probably seen it in utero?
So it's not so much that, it is, you think that your body has to see something and then decide, I don't like you. And then the next time I see you, I'm going to have an allergic reaction. But we see babies on their first exposure have allergic reactions. And one of the things that we think about, how is that possible, is we know eczema, severe eczema specifically, is a risk factor for food allergy. So
Mhm.
it is hypothesized that, we're being introduced, or the baby's being introduced to the allergen in the wrong way. So if they have inflamed skin, and there's peanut powder in the house, or somehow their immune system is being introduced through the skin and not through the gut, they can have a reaction when they truly eat it for the first time. So we are getting exposed to these allergens. Whether they're getting exposed in utero and for breast milk, we don't have enough information to say that that's a risk factor for the baby to develop an allergy to that protein.
This is wonderful information because I don't think in general pediatricians look at it that way. Can you speak to the concept that the first reaction, the severity? Because I've never, compared to older kids who have a repeat
Mhm.
exposure, I've never seen the full anaphylaxis in children. I see the vomiting and hives at the worst.
Yeah.
The first time it's gonna happen, because that's what scares parents, are you typically looking at the full broad spectrum from hives all the way to anaphylaxis for newborns,
I
or
have some bad news. It can
okay.
definitely happen. I've seen it myself. I've seen, when we do peanut challenges in the office to kids who are high risk, I've seen somebody have severe anaphylaxis to that first exposure, even with small amounts. I've seen, kids who do, certain milk baths is like a new thing where they take pictures and anaphylaxis. So it can happen. It doesn't, the thing about reactions with allergies too is past reactions don't predict future reactions. So one time it may be a few hives, the other time it may be anaphylaxis. And there's all sorts of things that, determine what makes the reaction severe. If a kid is sick and has a cold and there's already ongoing inflammation in their body, or if they're having an eczema flare, their reaction may be severe that day. When another day, when they don't have a cold, it may not be severe. So you can't really predict, and whether it's the first exposure or not, the reaction can be significant.
Interesting. And then for newborns, the like you said, we could maybe talk about the proctocolitis. I am generally screening when they're worried about the intolerance is not a medical term that we use in the office, but it's what is brought to our attention by parents, because intolerance can be anything. But I'm more worried about allergy, as are you.
Uh-huh.
If there's mucousy blood, a mucousy stool, I always want to check it for blood because that just tells me we're at a different level of problems here.
Yeah.
Would you say almost always if there's blood in, I don't know if you have any research on this, blood, when we do find hemoccult blood, that's hidden blood in the stool, is there a correlation, a very strong correlation with food allergy? Because that's when I go and start to do the whole workup.
Yeah. So it's it's food allergy in the sense that it's, most likely milk or soy, I'm sure, is, when you counsel your patients on what to avoid, and make sure that the mucus or the occult blood disappears. Yes, that is a food allergy, not in the IgE sense where, it's anaphylaxis, but we still call it allergy because it is an immune response and it is food related. But whether or not, these kids, I don't know typically how, when you counsel them when to introduce milk back into their diet, usually, by 1 year of age, um, it's not the same thing as a milk allergy where we're worried about hives and anaphylaxis.
Interesting. So they're two separate processes.
Two
And that
separate, they're both called allergy, just mediated by different parts of our immune system.
interesting. So I will often go ahead and test them for food allergy as they get older. And
Mm-hmm.
we do see them with the IgE on the Quest panels and other panels, but it still might be a different process. Or
So
at that
yeah,
point when we have that. Mhm.
I have seen babies who had proctocolitis and they have had milk allergy in the IgE sense when they're introduced to milk at the age of 1. And whether proctocolitis is, a risk factor for IgE mediated food allergy, or if it's just that delayed introduction of milk, which we can talk about in the childhood allergy prevention part of our talk. I don't know why specifically they're more increased risk. But when you're screening, for allergy for these kids later, it's difficult to interpret a test, the blood test or a skin test without history of actual ingestion at that point. You can have false positives.
So, yeah, I often see kids who are colicky, fussy. There's something's off with their stool. We do full
Mm-hmm.
workup for viral, bacterial, and it does turn out that they're having the blood and the inflammation, and we will then at that point alter their diet. But these children, I explained, will likely outgrow this allergy, and for them, that they're immediately more cautious about all other foods, and there's usually a family history with
Mm-hmm.
allergy, or if there isn't, I get less worried that there's going to be more allergies. If they are having these mucousy stools, would you recommend they see an allergist, or just the new thought is continue with foods and reintroduce as much as you're comfortable with, as long as there's no hives or vomiting
Yeah, so
with babies?
I don't recommend all kids with proctocolitis to see an allergist as much as I would love to see them. It's not really necessary. I think that once you eliminate milk, and soy, because like I said, those two are the two big ones, and the mucus and the occult blood or the gross blood goes away, then there should be no hesitation about introduction of any other foods.
Interesting. Okay. So as they start to eat foods, would you say these patients, this is where a pediatrician really straddles all the new data and has to decide, do I encourage them to start with at 4 months all of the allergenic foods? These parents usually aren't going to want to. What is your
Uh-huh.
stance on that?
So, this is again with so when we think about prevention, if we can actually just go into the next topic because it's like right hand in hand for this. So, you know, um, prevention is what makes all doctors kind of the most excited about being a doctor. You have a chance to actually prevent something, whether it be primary prevention, where you're preventing it before it even occurs, or secondary prevention, where they already have a disease and you're trying to prevent it from getting worse or progressing. But there is evidence that you can do primary prevention with food allergy. Early introduction of foods, specifically peanut and egg, have shown to help prevent a peanut and egg allergy. And so, the LEAP trial, which came out, many years ago, it was based on an observation that peanut allergy was lower in Israel, where they have, early and repeated exposure to peanut, prompted a trial to show that, infants who are exposed early can have a prevention in peanut allergy. So a consensus paper that actually came out and published in the allergy and immunology journals is recommending that to prevent peanut and egg allergy, infants should be introduced around 6 months of age, but not before age 4 months of age. So it is recommending that kids be introduced to these allergenic foods, between 4 to 6 months of age, whether or not they have risk factors. And at the same thing with complementary foods and other allergens too. Once you are introducing foods and they're tolerating some basic stuff, there should be no hesitation to introduce wheat and soy and tree nuts and seafood.
I attended some lectures. They were sponsored by Quest, so there was some incentive for them to encourage testing. But food allergy testing is available by lab for 3 months and older. For a very anxious family with a history of anaphylaxis, would you be comfortable with a pediatrician ordering that? Would you recommend it? Would you dissuade them from that? I often don't want to encourage. I know we get a lot of false positives, but
Yes.
if there is a concern, and is it Are we gonna miss a lot by doing it at 3 months? What are your thoughts?
Yeah, so I wouldn't do it at 3 months. It's a little early because the utility, when you order a test, it's only going to be valid for so long. You can't interpret a test at 7 months that you ordered at 3 months, and they're not eating at 3 months of age, really. So for time wise, I wouldn't recommend ordering anything at 3 months. Ordering tests in general is really, it's a complicated subject because, when I was fresh out of my fellowship and, you just want to be so evidence based and you want to follow rules and you want to say, well, this patient qualifies for testing or this patient doesn't qualify for testing. But when you step back, I really think about it as, what is my goal? My goal is for this child to be exposed to this allergen, so I can hopefully prevent a food allergy. And if that means a parent is going to say, I'm not comfortable giving this child my food or giving my child this food without being tested, I'm going to, agree to test the child, but have an understanding that we know that there's false positives. And if there's positive, it is our duty to give that kid a food challenge to let it truly define itself whether or not that kid is allergic. It gets really tricky when you start to order a bunch of tests, and we get confused or it's kind of controversial about what classifies a kid as high risk. Family history, an older sibling, they're actually more likely to be sensitized to that food, which means positive test, but not necessarily allergic. A parental history, possible risk factor, but the real risk factor that we know that is, we can't say it's not a risk factor, is severe eczema. So that one, if you have a kid who has severe eczema, I think sending them to an allergist when they're young is definitely beneficial.
And those are also the kids I struggle with encouraging that the parents start all of the peanut. At 4 months, I am heavily on all of these new products where 10 grams of all of the allergenic proteins are mixed into food or formula. And I have this strange sense, like this instinct you would have as a parent. Do I really want to do this? Do I want this is maybe only 10, 15 years of science saying that we should do this. Are you recommending with severe eczema, maybe those are the ones we should really be encouraging to start those foods with?
So those are the ones that are more likely to have a food allergy. So those are the ones that you would think that the early introduction would be the most beneficial. But those are the ones that also are maybe
So
at risk and could, see an
exactly that.
allergist to kind of stratify, which foods and if we want to do any pre-screening and stuff. But yeah, it is, we go back and forth years ago, don't introduce allergenic foods, now introduce allergenic foods, and it's confusing. And it definitely is anxiety provoking. But I guess at this point, we know for sure that it's beneficial for egg and peanut. It's possibly beneficial for, other foods too, but there really hasn't been shown to be any harm from introduction of a diverse diet at a young age. So it's kind of like, if I could possibly help, we should do it because there's really not a reason to not introduce it at this point.
So you haven't heard of children suddenly having anaphylaxis to these small introductions, something like Spoonful One and all of the competitors?
Yeah, I mean, I said earlier that it's a possibility, but whether or not that they were they were going to have it at 4 months or 6 months when you introduce it versus later. And we don't really know. The LEAP trial gave a specific amount of peanut protein that they recommended, to give each week to, prevent peanut allergy. But it's not really so much, how much is in the spoonful or one, or we don't have a known number of what's going to prevent allergies. We just know that regular, repeated, exposure to the food is what's important.
And can you speak to in pregnancy, there's all these food aversions, which genetically we think is maybe a way to protect you from
Hmm.
eating dangerous foods. There's lots of theories out there. But you do have an opportunity to introduce different proteins to the growing baby. And is there any study or speculation that if you continue on all the allergenic foods during pregnancy, you might decrease the risk for your child to have allergies?
So we don't know, we can't say that it decreases or increases. The only real consensus statement is that, there's no or maternal exclusion of allergens during, nursing or during pregnancy is not recommended. So we're not saying, you should do that, whether it's helpful to give it, I don't know, but it's not recommended to avoid these things. I ate peanut butter on a daily basis when I was pregnant. Whether or not I subconsciously thought I was doing something or I really was just craving it, I don't know. But
2 a.m. peanut butter banana. It works like a charm.
graham crackers too.
What other tips would you recommend for preventing childhood allergies? And when I say that, I'm discussing allergies such as asthma-induced allergenic asthma, or from the environment, or nasal allergies.
So just all in general, yeah. So just to finish up, the food stuff, early introduction is important. Don't restrict, maternal diet during pregnancy or lactation. One other thing that comes up real quick is, the use of hydrolyzed formula, as a prevention of food allergy. That's kind of been thrown around, that's not recommended. And then, breastfeeding is always universally recommended exclusively until the age of 6 months. But if there's no association with food allergy prevention. So I just hate for there's many different reasons why moms don't breastfeed, and 100 different reasons. I don't want anyone to feel that they're doing a disservice from a food allergy perspective by not exclusively breastfeeding their kid. Other things that are good for allergy prevention is if you have eczema and you have that disrupted skin barrier, you're increasing your allergen sensitization. So, you're exposing your body, like I said, the wrong way to allergen. So really working on eczema management is a good way to prevent allergies in general too, repairing that skin barrier.
Have there been associations with other allergy syndromes in the body, like allergic rhinitis or asthma, due to eczema? Is that
so? Eczema is kind of considered like the first in the atopic march. So we say that kids who have eczema, they go on to have allergic rhinitis, asthma, food allergies. So when I mentioned before, secondary prevention, if you take a kid who has eczema and you can kind of halt that atopic march by treating their eczema and preventing, further sensitization. Other things that are important for allergy prevention, things that come up, elective C-sections. That's like a thing now, it's all about the microbiome nowadays too. So, just early exposure to antibiotics. People kind of get excited when their kids are sick and they're requesting antibiotics when, it's our job as physicians to really encourage the use.
To clarify for people watching, the microbiome that people acquire, or infants, newborns acquire, is the bacteria from the maternal passages. And those are missed when you do a C-section, so that there is a consideration that maybe the child doesn't have the full bacterial environment necessary to protect them from allergies. Is that right?
Yes, it's perfect. Thank you for clarifying.
I know we have to remember that you and I have the same background, but the second comment you said, and antibiotics, when you're treating a sinus infection, which is rare for children, or a pneumonia or an ear infection, you're destroying other healthy bacteria that balance out the environment that keeps sometimes barriers to our external world.
Yes,
in the
perfect.
gut, in other places, in the mouth, everywhere. In the nasal passages, everywhere. Okay.
And then other things that affect, the microbiome, which affect allergies too, being too clean, or, send your kid to daycare, let them, get their exposures. Trying to think of what else. Kids with older siblings tend to do, better as far from an allergy perspective. Even having, furry animals in the home. There is some studies that suggest, maternal exposure to dogs can
Oh,
be protective against allergies. Um, but yeah,
I'd like to
otherwise
ask about
prevention.
the exposures at school. The older I've gotten, I think we overgeneralize that because here just this morning I was running late because I saw a kiddo with RSV. And we do know, and there's clear links to cancers and allergic processes that start because of a virus or infection.
Mhm.
So while I encourage, the exposure, I always feel like once you hit maybe two, three, four, you're a lot better off. You won't get the ear infections. You won't. So I know that we talk about getting dirty, but I don't think getting dirty equates necessarily to I want my kids to get all of these viruses
Yeah.
when they're one. And I don't I'm not one to speak. I'm not an immunologist. I'm not one to speak on that, but in my experience, if I had to weigh the risk benefit, I would say if you're at a very dirty preschool and it's the winter and your kid has been getting a lot of ear infections, you might want to, rethink what their exposures are. But do you see that being a detriment? Are you talking about also getting exposed to the infections or more just the dirt?
Yeah, no, I agree with you completely. I would never, no, wish upon, my 6 month old getting, RSV
No, and
or,
yeah, but it's just so people ask all the time, like, isn't, but don't we want them? And even my husband, like, why are you taking our 3-year-old out of preschool right now? I'm like, well, COVID, flu, and RSV. And
yeah,
that
those are scary.
not
There's a
those
scary
kids.
trifecta
And he
right
goes,
there.
isn't that good for them? I'm like, well, we know like B-cell lymphoma and all these things happen from DNA changes from these viruses and bacteria. So I'd rather not.
Yes.
But
No, I agree. I'm just thinking, more in general, when you look back and you think about what affects the microbiome and what affects your risk for allergies, these are things that we think about, whether or not we make, recommendations based on these observations is another thing. But it's just something that, yeah, like a dirty, staph colonization on your skin, those are important. That's a risk factor too for allergies. So yeah, you there, I guess it's finding a balance of being clean and dirty but not too clean and not too dirty, is this what
yeah,
I would say.
I've never like brought this up as a conversation with another doctor, but in my office, it's definitely a risk benefit because we don't know much about how
Mhm.
much dirt your child needs or, infection to protect from allergy versus we see some of the other things going on with infections. So,
That's a good headline, not
yeah,
much dirt is too dirty.
yeah, and I think sometimes dirt is, mold. Yeah, it's all things that can affect us adversely. So it is a weird place we're in right now after a pandemic to figure out what is a good norm for people.
Yeah, this is
Um,
definitely a time that's going to make us, reevaluate our feelings on that too, especially as we're seeing these increases in colds and RSV right now going around. It's pretty frightening.
yeah, I think we're a little bit in shock after the pandemic.
Exactly.
People have turned to two extremes. So, do you want to move on? Is there any last comments about prevention?
No, I think that that's I don't want to overwhelm. And I think that we talk about allergies and treatment of allergic rhinitis, which we could talk about too. That's another way to prevent, asthma and more allergy rhinitis. So we'll touch base on
Great.
prevention
I just
again in
moved.
the next
Yeah,
one.
I just
Oh,
moved.
perfect.
Okay, good. I just moved us to that because I look in everyone's nose, and I myself don't have allergies that came up on testing, but I'm a new person when I use that. I started Flonase, now I'm on Sensimist through the recommendations of a pulmonologist that Sensimist is a little bit more better tolerated. But I love talking to all my patients when I see the swelling in their nose that they could
Hmm.
have such a better life with
Yes.
nasal spray, and then I have to step through all of the uh, concerns. So you can maybe speak to that.
Yeah. And I love that you said, such a better life with using it because, I get defensive. It's not just a runny nose, it's not just snot. I mean, it really truly infects your quality of life. And so I appreciate that, you said that. When we say allergic,
Uh-oh, I just lost her. I will see. Her connection was probably lost. Yep, you're here. Let me put you back in the stream. You'll be right here in a second. There you go.
oh, sorry
Go
about
ahead.
that. Not quite sure what happened. Happy to be back. So I just want to say, allergic rhinitis, what is that? That's just the fancy way of saying, allergy, the nose symptoms related to allergies. So, sneezing, runny nose, congestion, itchy nose, which then, can also lead to drainage in the back of your throat and cough and, that postnasal drainage.
Can I
So
add
allergic, right?
two symptoms that show up that parents don't even notice? This or this, and parents won't see this, but if you see a line across the nose, that's called the nasal crease from a nasal salute, and your kid, they'll say, no, I've never seen my kid do that, and the kid's sitting on the table doing this, and I'm like, well, that, and they're like, oh, maybe they do. So if there's
Yes,
a line across there, I'd say 1 in 100 it's genetic, because they'll say, oh, I have that too, I don't have any symptoms. But if they have that crease, they already are having inflammation that's changing the anatomy inside the nose, not just out.
100%. Yeah. So the allergic salute that you mentioned, we also say allergic shiners, where you get the darkness under eyes from the changes in the blood vessels and the dilation. There's also little lines under your eyes that we see. If you look in their mouth, you can see like a high palate from mouth breathing. But that noise that you mentioned, that that frequent throat clearing, and also when we first started dating, my husband made this noise. He's gonna be mad at me, but you're trying to scratch the back of your throat by doing that. Like, I can't even do it. Those are signs too.
I don't
Which
think
she
there's
has on Flonase.
I don't think there's a female out there who hasn't desperately done whatever they could to get their husband either a sleep study or on Flonase.
Yes, exactly.
It was in my household too. Yeah.
So, the treatment for allergic rhinitis, varies. There's oral medication, antihistamines. When we think of antihistamines, I'm not talking Benadryl. I'm talking about the newer second generation antihistamines, Zyrtec, Claritin, Allegra. And those are nice because they don't cross the blood-brain barrier, which means they don't have the same, sedating, effects as Benadryl. Of course, some people can still get fatigue from them, but it's not as common as, people taking Benadryl. Other treatment
Which of those
options.
is your favorite for kids? Which do you prefer for allergies, not for colds? Because I like Benadryl on and
Yeah.
off.
Yeah, so for
Which
cold, it's really the anticholinergic of Benadryl that dries them out. But for allergies, I have some people that say, Claritin works best for me, and I have other people that say Zyrtec. My number one go-to, and it's more just I have just enough clinical response to it, is Zyrtec. That's kind of my go-to one.
And that's one
But
of the
again,
safe, right? Yeah, I mean, we see
yes.
people, you can use that in infants even, correct?
Yep, I give them to infants all the time. I start them, really young, and you could be on Zyrtec for years and years and years, and I don't anticipate any long-term effects. It's not going to cause liver damage or kidney damage, or so yeah, I generally feel very comfortable prescribing those medications. I always say there's no such thing as a perfect medication, but I feel very comfortable prescribing it. Nasal sprays are great. I think nasal sprays are actually really one of the most effective medication for the symptoms of obstruction, congestion, that mucus draining in your throat, because you're really focusing on those cells, you're shutting off that mucus production, you're decreasing that inflammation. Nasal sprays are, there's nasal antihistamines and there's nasal steroids. And when we hear the word steroid, we all kind of, steroid. But it's not a systemic steroid. This is a topical steroid. So, you're putting it directly on the cells. It's not like taking prednisone where your toes and your fingers and are getting the same steroids. So, we get concerned, is there an association with decreased bone density or growth suppression or cataracts and things like that. But clinically, these are not, findings that are reproducible. We don't see these things to worry about it.
Yeah, and
So,
these are from oral doses, usually more than twice a year. I like to explain that people who use an inhaled into the lung bronchodilator that is a steroid, that or it's not a bronchodilator, it's a steroid, an anti-inflammatory. You're taking if you take that once a day for 2 years or twice a day for 2 years, it's the same as one oral dose of a steroid, which some people end up, if they aren't controlling their symptoms, they're going to end up on an oral course of 5 days, twice a day. So that would be years, like, 20 years of using an
uh-huh.
inhaled steroid. So I really try to capture that for the parent to be a little more proactive with using the steroid that is localized. There's really very little possibility for it to be travel through your bloodstream and hit your adrenal glands or any other endocrine function.
And that's so important. And it's definitely a lack of education, or awareness for parents, knowing that. But 100%, it's like I say, it's like taking cortisone cream and rubbing it on your lungs. It's not, when you use the inhaler, it's not the same. It is so much safer. And if you are proactive about your prevention, and you even prevent one course of oral steroids, you are doing such a service for your child. So it's so great that you talk to your patients about that. And it's the same thing for the nasal spray. It really is important to treat these allergy symptoms.
Mhm.
And it's not, like I said, just quality of life, but there are things that can happen if you don't treat allergies. You can lead to sinusitis and, require antibiotics when you're obstructing the complex, and from the nasal congestion. Untreated allergies can lead to asthma exacerbations. It's one airway. So if this is obstructed, it's really hard to control your
And
asthma
yeah,
as well.
and we see that
Um,
I see in my practice the kids who do have a lot of allergic rhinitis untreated, many more colds, and their colds last so much longer and do, like you said, lend to having sinusitis, which is so rare for kids. You're not supposed to have sinusitis because you're supposed to have nice big openings that everything
uh-huh,
drains. So if your kid has
exactly.
sinusitis, you probably are in need of using a nasal spray. And the nasal spray that is now in fashion is called Sensimis by Flonase. Is that the one you would recommend?
Yeah, I mean, I don't really have so much preference. People like the Sensimus, and it just
Mhm.
sounds, it sounds nice. The mist,
Alcohol free though.
yes.
But for bloody noses, it does make a difference.
Yes, for bloody noses it does. And technique is so important too when you're using these nasal sprays, so there are adverse reactions with nasal sprays. You can get bloody nose, you can get dryness, but if you're doing it the correct way and you're aiming, where you're supposed to be aiming. So, I
You want to
always
speak to
kind of
that?
do
Yeah.
this funny little hand dance when I'm showing my patients,
Please show
but
us. You have to show us.
yeah, so opposite hand is always easier to point in the right direction, because otherwise you kind of have to do this weird wrist flick thing, because you want to point to the, your ear or the corner of your eye. So I like to do opposite hand. You spray, and then people find the need to really inhale after. You don't need to do that. If you sprayed your Flonase outside your nose, you would see how far the spray goes. Your sinuses are right here.
Yeah.
Okay. So if you sniff aggressively inwards after, you're just putting it right into your throat. And then your kid's going to complain that it tastes gross and it's
Yeah.
making the drip in their throat worse, and they're not going to use it. So I just, a little spray, and that's it. You can do a little like bewitched sniffle, other side. And then if you do two sprays, you just want to alternate, because if you do two sprays at the same time, it's a lot of liquid. in, that period of time.
Yeah, I always tell people to just go where the air travels in their nose. So I just say directly up, but you would like them to angle towards the turbinate outward?
Towards the ear on that side. Yep. And then usually when they do it the correct way, they're more likely to be compliant because it doesn't
Hmm.
bother them as
Mhm.
much. It's not in their throat and they're not hitting, the blood vessels on their septum if they're aiming inwards, which is causing the bleeding. But yeah, so I mean, usually nasal sprays are really well tolerated. And again, we're trying to prevent, the ear infections, the asthma, the sinus infections. And then something that I think is also, important is there is a association with, psychiatric and cognitive issues of kids who have untreated allergic rhinitis, whether it's not because they're sleeping great at night because they have this sleep disordered breathing, but there is higher levels of ADHD, low test scores, poor concentration in school, from not getting that good night of sleep. And even then in school, if they're constantly blowing their nose and not focusing on what they're learning because of their allergies, those are really important things I think that need to be addressed besides, the medical complications of not treating allergies.
Yes, I'm so glad you mentioned that because obstructive sleep apnea in childhood is a real problem.
Mm-hmm.
And it can present as behavior issues, disdain for school, tired, fatigue, but you might just see that they always seem cranky or the ADD, ADHD. But let's say you're going to see an ear, nose, and throat doctor and you're scheduled. They are always going to have you come back after a month of using a nasal spray and an antihistamine. So do yourself a service. And if your pediatricians mention something to the nature that you have very swollen turbinates or allergic rhinitis, stick to it for a whole month. If you have to give a
Yes.
Tic Tac when they take the nasal spray, you can do that, the sugar-free Tic Tacs or something in the mouth. But stick it out for a month and even ask your kid, do you feel better? Wait a week, but do you feel better? Sometimes they'll say no, and then it's worth talking to the doctor, say there's no improvement, and I've seen that before. Once I've been surprised though, the child had full dust mite allergies, so he was a teen, and I just think he didn't want to use it. But it is something that your doctor is gonna if you're gonna take it to the next level because you're worried about recurrent ear infections, right? Because that's a problem. If your kid has recurrent
Mm-hmm.
ear infections, you better be on a nasal spray. If you're worried about them breathing with their mouth open at night or their behavior, just everyone should be trying a whole month on it. One spray each
Yes.
nostril, 2 and up. Under 2, sometimes the allergist will recommend it, but age 2 and up can use Sensimist and 4 and up for Flonase, right?
Yeah, so it's not FDA approved under the age of 2. I still, if a child needs it, I'm still going to recommend it. That's what the whole doctor patient, having a conversation, explaining, the importance of trying it. But the month you mentioned is the trial period that I say too. And it takes about a week, or so of even using it before you even start to notice a difference. So hands down, the most common thing I hear is, oh, I tried Flonase, in the past. Oh, really? Yeah, I did it for 4 days in a row and then I stopped. So when we say try it, you really have to try it, which is a full month of using it and using it daily. It's not going to work if you're just using it 1 or 2 days a week for that month.
Right. So in summary, we can prevent ear infections, sinus infections, progression of asthma, cognitive issues, obstructive sleep, prevent getting your tonsils adenoids out because you might just need to be using a nasal spray. So great. Thank you for speaking to that because it's a constant battle in my office. I'm the simplest things for someone who doesn't have allergies, it's changed me. So
Yeah.
well, allergies on paper, so something's triggering in. We all do have sensitivity to dust in the air and get inflamed. It might not be a full
Yes.
allergy, so that's why it can help anyone.
And
So
that's really important. Yeah, there's a difference between, a dust, like an irritant, versus dust mites, allergens. If you open up a box that's been sitting in your attic, and dust flies in, you're going to sneeze and, you're going to have some inflammation. That's different than having a true dust mite allergen. And irritants and allergens, Flonase actually is helpful for non-allergic causes of congestion that you mentioned too. So
which
I
is, I
think
think,
we
why
just did a full commercial for Flonase here.
you can get generic. I'm all for any generic.
Yes.
I just find that the price differential is minimal. So eczema care, let's move to that. That is such a big topic. We probably need a whole show on that.
Yeah, I'm
Go
going
ahead.
to try my hardest to keep this one
Yeah,
kind
we
of
have,
concise.
yeah, we have 10, 12 minutes. Go ahead.
Okay, so eczema, babies get all sorts of rashes. I'm sure you have parents coming in. There's baby acne, there's eczema. My kids had this thing called erythema toxicum. They looked, it was very scary for me as a first time mom having my kid come in with that. But point being is, kids get a lot of rashes. But eczema is really when you have that chronic itchy inflammatory skin, and there's clues based on how old your baby is, whether it's eczema, where it's distributed, things like that. But when I'm just gonna say, once we know it's eczema, how do we manage it, and things that we can do. And it's important not just for the kid to be comfortable, baby's not sleeping well, parents not sleeping well, all of this from eczema. But we mentioned earlier that it's also a risk factor for allergy sensitization. So you really want to treat eczema in that regards too. So, goals of eczema: one, reduce the symptoms, treat the current skin and prevent future exacerbations. So what are common things that can be done for eczema? You really want to keep the skin hydrated. Really, you just got to apply moisturizer. I always tell my patients, and they can hear my voice probably saying this, your kid should be almost shiny. When you have eczema, like, you can't overdo the topical emollient, really.
And can you explain emollient? Because that's this, I go blue in the face saying, just forget about lotion. It's going to evaporate. Do the
Yes.
emollient, the cream, the thicker,
So
the better.
when you think of, it's kind of a spectrum of what's most hydrating. So lotions are going to be the ones that come in a push top. Those evaporate from the skin really quickly. Those are going to be the least hydrating. And then there's the creams, and the creams are the ones that are going to come in a jug or a jar where you have to, scoop your hand in. Those are definitely more moisturizing than the lotions. And then the most moisturizing or the most hydrating are going to be your ointments, your things that have your petroleum in them, the greasy, whether it be Vaseline or Aquaphor or CeraVe. So you definitely want to use more of a cream and an ointment when you're thinking about hydrating the skin. And sometimes it's hard.
A lot of parents get fearful about petroleum. These are the same people who are reading all the toxic side effects of a nasal spray. So you have to explain that the petroleum it is found in nature. It's found in rocks. It's okay. Do you ever have to address that? Do you get that in your office that they're like, they don't want to
Yeah,
use it because of petroleum?
a lot of
What do you
different things too. I guess I just address it like how what you just said. It's not. I maybe should have more of a handout or something to give them. But I really just I don't have any concerns about the use of petroleum on your skin. I don't the bad rep that it has. It's actually shown to, if you take people with eczema and put petroleum, you actually can push the skin more towards normalization with petroleum alone. So I am a big supporter of the
Yeah,
petroleum. Yes,
it's just hard. It's hard
it
combating whatever mom blogs are out
it
there.
is really hard,
You're not gonna find
and
a
people
doctor
come
bad
in.
mouthing petroleum.
Yeah, and they use, they say, I want to use natural, and I want to, this is essential oils and these things, and I always say, natural doesn't mean necessarily good. Poison ivy is natural. Do we want to rub that on our skin?
Exactly.
No. So things that smell nice and have essential oils and things, like, yeah, maybe for someone who doesn't have eczema, those things are wonderful, and feel free. But if you have eczema, and you have irritated skin, simple is better. You don't want to use these things. You want to use the ones that we know are not going to irritate the skin, because we're trying to eliminate all irritants. So, what are other irritants? Detergents, anything really that has a fragrance to it. Soaps and shampoos and baby stuff that make your baby smell, wonderful. Your baby smells delicious regardless. You don't need that extra stuff to make your baby smell good. Um, hot, long baths are not recommended. Frequent bathing is getting that skin wet so you can apply the moisturizer and lock in the hydration, but you don't want to do anything that's going to dry out the skin. So, like with the strong detergents and things like that. One of the things that I've seen also is parents will wash their baby's clothes in, fragrant-free or, dye-free detergent, but continue to wash their own clothes and blankets in detergents that have fragrance and dyes. And then, what do you do with your infant when they're young? You hold them and they're on you and they're on your clothes that have those detergents too. So if you have a lot of eczema in the house, I recommend washing everybody's clothes and all blankets in those detergents. So, eliminating irritating factors, too much dryness, too much heat, hydrating the skin, can't overdo it, daily short baths. And then when you have eczema, treating the inflammation. And it's one of those things, again, where the word steroid is used and we get super anxious, but when done right, you're using these steroids in a very controlled manner and in a way where, we're doing short courses. I would never recommend, daily use of steroid for weeks and months on end, but you really have to stop that inflammation.
It's so interesting. And when I look back at the fights I have to fight to explain things in lay terms, I've never had that with a eczema patient, because they get to the point where they just are calling, give me the steroid. I'm like, okay, well, let's figure out what you're doing. And these are any type of parent, whether you're completely a granola parent or not, you need to stop the inflammation with the steroids. So it's interesting how anything that you can't see in the nose, but you can see their skin's cracked and bleeding. You're like, I need to stop this. I can't stop it on my own. I need the steroid. So people they're very compliant with getting a steroid cream on that skin when it's cracked, but preventing it. Have you ever recommended monthly or weekly? It's rare I do this, bleach baths for people who get recurrent infection.
Yes, I
You
do.
will.
I do
Okay.
bleach baths all the time. Thank you for bringing that up. So everybody has bacteria on our skins, but when you have staph, there's actual chemicals, that are increasing the itch. And you can't control eczema without controlling the itch. Eczema is the itch that rashes. So if you're itching, you're scratching, and your eczema is flaring. So just decreasing the colonization, or the presence, try to use my good term, sorry, the presence of bacteria on your skin is just an easy, it's not a medication way of helping your eczema. And even if it doesn't, it still just counts as a daily soak in grease method too. And people freak out a little bit when you say bleach baths, but you're diluting it so much that it's not. I would never ask somebody to dip their kid in a tub full of bleach. This is diluted to the point where very minimal bleach.
Great. Yeah. I remind people, you're making the same concentration as any pool you go into. You're just making it cleaner in your own home.
Yes, without all the other pee from other kids.
Yes, and that top layer, that top foam where you get your molluscum, you get your warts, you get your staph infections, right at that top layer when you're getting out of the pool. I can see it.
Oh God, gross.
But yeah, eczema is very prevalent. Pretty much it is like a continuum, right? So you see dry skin on people, just any kid, get that dry skin sealed. I do find that there is always the cradle cap connections. If they have cradle cap, and I always look right behind the ear right here in newborns, if there's it's not dirt, it's usually flaking, and that's a first sign of eczema, that your child's gonna have eczema. If you had eczema, if you have asthma, if you have allergies, get your child lubed up, shiny. And then
Yes.
yeah. And then I see that these kids tend to be a little bit more, they have some dissociation of their top layer of their skin, right? I have an analogy of a red brick wall, and you have mortar that's not sticky enough. So people with eczema are not producing the right type of sealant between their cells. And if you pretended there was rebar between those red bricks, your rebar is more mobile. So everything rubs and opens, and the bottom layer of skin sees the external world and says, oh, this is dangerous. Let's attack it. But it's really something that's benign, but you get the itch and the inflammation, and it becomes this endless cycle. So whenever there's some unhealthy skin, I like people to just get that cream on it, on the kiddos. And after bath, you
Hmm.
seal in the moisture, and you start doing it as a regular routine. That said, I have a 7-year-old boy who doesn't, well, once you start doing sunscreen, they don't want you to put anything on their bodies. So
It's always the boys too, and I don't know. I'm not gender stereotyping, but it's the younger boys are the patients that I really struggle with getting the lotion on. They just don't like it, and the ointment is almost impossible. So. But if you're gonna do something, at least get the minimum of a cream. You know.
and yeah, and then layer them up with their clothes so it stays and it sticks.
Yes.
I've had very bad experience with oils. They just don't last very long on the skin. You don't recommend that, right?
Yeah, I have the same. I don't like the oil use. There was this whole thing, also anything that has a potential, protein in it that you don't want to introduce the skin. I mean, the level of coconut and coconut oil is not that high, but I still just don't want to put anything like that on inflamed
Interesting.
skin. I don't want to introduce it to the immune system that way.
You know what drives me nuts, which it should drive you nuts too, I'm sure, when you find the hydrocortisone that's like extra soothing and has all these other ingredients, and I'm
Oh,
like, oh my gosh, this is a cream we're using for someone who is sensitive to something, and you're adding more
mm-hmm.
ingredients. Please stop. I like will be on FaceTime while they're at the grocery store. I'm like, no, not
Oh,
that.
me too.
No, not that one. No, no, not that one. Okay, look at the inactive ingredients. It's like 10 things long. I'm like, no, just get the
Yes,
cortisone.
if it's a paragraph, put it down. Yes, I'm
Yeah,
the
I know, and
exact
that's
same way. Just plain hydrocortisone,
I know,
1%, nothing else.
like, yeah, more not the moisturizing one, but, yeah, I think it's all just branding too, because I went through it and I'm like, "I think this moisturizing one's okay. I think they're just using the same cream, calling it moisturizing."
Yeah.
Anyhow, we have run out of time, but, I can tell you're so passionate about these same topics that I could go on and on and on and about, because it saves people doctor's visits, so thank you.
Thank
And maybe
you.
we can do part 2 with asthma, because that is such a critical conversation, especially in winter season with all of the.
I would love that.
So if anyone wants to find you and wants mobile home services and assessments, they can find you at Ryan Ray Skin, right?
Yep.
And
There's a phone number on the website. There's an online inquiry. You can fill out your name, texting, calling, whatever. I'm here.
great. Thank you so much for being here, and we look forward to part 2.
All right.
Have a
Thanks for
great
having me. Enjoy the rest of your day.
bye-bye.